Utility of 2D-4D transperineal ultrasound for the evaluation of anti-incontinence, surgery complications, and/or failure. We will describe the findings in a series of patients with symptoms following probable anti-incontinence surgery complications and/or failure. Anti-incontinence surgery aims to repair urethral and periurethral anatomy and function. Transperineal ultrasound was performed on patients who presented symptoms of void and dysfunction, incontinence, infection, or pain after anti-incontinence surgery failure. The exams were performed with a Voluson P8 equipment and a volumetric convex probe. The evaluation of the location of the slings by means of transperineal ultrasound must be carried out in the sagittal and axial planes and 3D reconstruction in the axial plane. Suburethral slings can be identified as an echogenic structure between the anterior vaginal wall and the posterior wall of the middle urethra. There are two types of slings, TVT, tensionless vaginal tape, and TOT, tension-free transobturator tape. In the sagittal plane, the differentiation between the two is difficult. The 3D transperineal ultrasound allows to demonstrate the shape of both. The TVT sling is observed in the shape of a U and the TOT in the shape of a C. We can see in figures A and B a mid-sagittal two-dimension transperineal ultrasound of suburethral slings marked with arrows, TVT on the left and TOT on the right. The differentiation between them in this plane is difficult. In C and D, we can see a schematic representation of the pelvic floor and location of the suburethral slings, TVT on the left and TOT on the right. On figures E and F, a 3D reconstruction in the axial plane shows the tapes are evident as U-shaped or C-shaped echogenic structures surrounding the urethra laterally and posteriorly, allowing us to identify the different types of suburethral slings. Notice TVT on the left and TOT on the right. The dynamic evaluation at rest and against Valsalva maneuvers allows to identify the dynamic tension performed by the sling by compressing the urethra. In A, at rest, the suburethral sling, marked with an arrow, can be observed behind the middle urethra, and in B, against Valsalva maneuver, it is observed how the suburethral sling, marked with an arrow, distends and compresses the urethra against the pubic symphysis. In the video on the right, it is observed how, against Valsalva maneuvers, the suburethral sling descends and approaches the pubic symphysis, producing a compressive effect on the urethra, thus demonstrating the mechanics involved in the therapeutic effect when it is placed with adequate tension. But when surgery fails, what is the contribution of 3D transperineal ultrasound? Well, we must identify the lack of tension or excessive tension in the mechanism of action of the slings at rest and Valsalva maneuvers and describe what consequences each case has. In low tension, incontinence persists. With excessive tension, it compresses the urethra and causes emptying dysfunction. A sling with low tension is observed locating behind the urethra, very far from the pubic symphysis at rest in the figure on the left, and remains away against the Valsalva maneuver when you can see on the video on the right. As a result of this location, the expected compressive mechanical effect against Valsalva maneuver does not occur. The distance of the sling to the pubic symphysis should not be less than 15 mm in Valsalva. The video on the right shows the dynamics of a sling with low tension against Valsalva maneuver. It descends, but in that descent, it does not approach the pubic symphysis, compressing the urethra. In figures A and B, and in the video on the right, a sling marked with an arrow is observed with excessive tension. It is located behind the urethra, compressing it against the pubic symphysis at rest in figure A, with little or no mobility against Valsalva maneuver in figures B and video. The distance of the sling to the pubic symphysis should not be less than 7 mm at rest. You can observe how the bladder is distended since the patient has emptying dysfunction. In Figure A, we can see the result of the sling resection, marked with an asterisk, to solve the emptying dysfunction caused by a sling placed with too much tension. In Figure B, a second sling, marked with the white arrow, is observed in a patient who had already been operated with the first sling, marked with a black arrow, that due to its insufficient tension did not produce the desired compressive mechanical effect. In A, it is observed in a coronal section that the left branch of the sling, marked with arrows, has an abnormal path to the most cephalic region of the urethra and contacts the bladder neck. In B, an endoluminal lithium, marked with an arrow, is observed attached to the wall due to the erosion that the sling produced at that level. In the videos on the right, is it observed in the sagittal plane scan above and in the coronal plane below how the left branch of the sling presents a capricious path in the cephalic direction towards the bladder neck. In Figure A, there is a sagittal section showing the suburethral sling, marked with an arrow, located in front of the urethra and behind the pubic symphysis. That location is the result of chronic erosion of the urethra by the sling and its migration to that location. It is a slow process that allows spontaneous repair of the urethra as it happened in this case. Let's remember that the normal location of the sling is behind the middle urethra, between it and the vagina. In Figure B, a scar-type calcification is observed at the level of the urethral wall, marked with an arrow, a consequence of the erosion process of the urethra. On the lower right, a video showing a scan from anterior to posterior in the coronal plane, where the pubic symphysis is first observed, then the suburethral sling, and finally the vagina, when it is the urethra that should be seen immediately after the pubic symphysis. In conclusion, transperineal ultrasound is a low-cost imaging method that allows the visualization of slings in real time and in a dynamic way. It is an excellent tool for the evaluation of failures and/or complications that may arise after anti-incontinence surgery. Thank you very much.